Well, thanks very much, Dan. We're going to learn that Dan is not only smart, but brave. Having a mere clinician talk to a bunch of brilliant scientists is a bold move. So I'm going to talk about the clinical perspective regarding vision. And we've talked a lot about why vision crosses, why there is representation in each eye that's brought to one side. It is important for depth perception. And we know that in the transmission of this information through the primary visual pathway, that it's very retinotopic, meaning that there is a point-to-point relationship in these projections, and these relationships become more and more congruous as we head to the primary visual cortex. These attributes, remarkably, that were just talked about, are carried in a single bundle on their way, but they're segregated in that bundle. And note that once this projections reach the primary visual cortex, there is a cortical magnification factor. Central vision is so important that 60% of the visual cortex is dedicated to those central 10 degrees. And this is an example, a clinical example of a patient of mine that demonstrates this remarkable phenomena, and where radiologists and neurologists need to communicate better to understand the structure and functional relationships of vision. The top photograph there just shows a central scotoma that is right here, only 10 degrees, very tiny scotoma. Yet, look at the cortex back here, and the damage that was seen in the visual cortex was quite dramatic, representing 60 to 70% of the primary visual cortex. And it is therefore these relationships that are so important. Everybody knows, therefore, that when we injure the primary visual pathway, we get darkness, almost always. If we hit one eye, we're blind in one eye. If we hit that chiasmal area where the various fibers are crossing, we'll get the classical bitemporal hemianopsia. From that point on, from the optic tract through the geniculate, to the temporal radiations, the parietal radiations, and the visual cortex, will get a hemifield defect. I would contend also, Dan, that depth perception is driven a lot by both eyes, but its importance is in those first few feet. Okay, try threading a needle with one eye. I don't advise it, okay? But looking at distance, depth perception with one eye is pretty good, but up close, not so good. We also know that the primary visual cortex is only the start of where vision begins, where we interpret lines and bars and angles and edges, but there are specialized areas in a sequential fashion that allow us to understand our visual world. There are areas that are largely dedicated to interpreting form, color, movement, spatial locations, distance, and object identity. In fact, about 55% of the human brain is dedicated to vision. And it is the essence of our behavior. We are visually driven animals. What we see greatly influences our behavior. And this is from the classic article in Cerebral Cortex from 1991, where they map out these visual areas in the monkey, and there are at least 32 areas that are related to the visual neocortex. So in a clinical perspective, we tend to divide the visual world into two big streams: a dorsal stream, parietal occipital stream, to help us understand where things are. And we'll see patients that have lesions in this system will develop, and we'll discuss it, Berlin syndrome, and there'll even be dramatic examples of people that are motion blind, that see pouring water as a frozen glacier. And then there's the ventral stream in this very simplified approach clinically, the what system, in which if we injure it, the patient will be colorblind, they may not recognize objects, they may not recognize familiar faces, or they'll have a disconnection where they'll be able to write but not read. And we'll show you examples of these patients, and we still need to better understand the anatomy behind them. So here is a cartoon of what some of this looks like. And this is to say that in V1, the primary visual cortex, we see black and white and lines and bars and so forth. And we begin to interpret what an object is by the segregation and the summation that it goes through these various areas as we move forward from the visual cortex. So in the bottom part of the slide, the ventral part of the slide, we can see that area V2 that surrounds V1. We begin to see color, we begin to see collinear lines be brought together, further brought together in geometric shapes and better resolution and color in area V4, all of which will be important for us to interpret a face in the inferior temporal area. If we move dorsally, we're looking more at the motion side of vision and the area MT and V5, so important in understanding visual motion, and area V6, understanding motion of your body, or motion of your hand, relationship to your body. So I want to take you through a series of cases that demonstrate some of the most extraordinary cases in neurology. And the first case is what we call Anton syndrome, a denial of blindness, and the phenomena of RIDAC, where motion can be detected in a blind field much better than static imagery. This unfortunate patient suffered a respiratory arrest in a restaurant after eating fish. A bone got caught, and for 13 minutes, he had an arrest. I then see him in the neurointensive care unit here, and he'll describe what he thinks I look like, but he's confabulating, making up what I look like. Okay. You'll see that he thinks I'm Superman.
What color is the outfit?
Black. Gold buckle. And then blue.
And can you see my hair at all?
No, I can't.
Can't see the hair. Can you see my face at all?
Yeah.
Not yet. But you can see, you said what I'm wearing, and that is Superman suit.
So he thinks I'm wearing a Superman suit. He sees a gold buckle. He saw black leotard pants. I'm pulling out money now, and then I'm going to ask him what this is I'm holding.
What am I holding?
He said, I'm holding a mirror. Then I'm seeing if he could really track it, which he wasn't tracking it.
And how about, can you look at my finger?
Yeah.
Can you follow?
He obviously looks down, doesn't see my finger. He was not tracking at all. But something interesting happens here.
Are you able to grab my hand?
Couldn't see my hand, obviously.
Grab it. Do you see anything that I'm doing right now?
This is static
Card
data.
trick
So
looks like.
card trick?
Or
He says, I'm
shuffling cards?
performing a card
Shuffling
trick,
cards?
shuffling cards. So he does see some
How about over
motion
here?
there. So now we look at his imaging. And you're a bunch of hero type neuroradiologists that here. The findings, despite the dramatic clinical findings, are quite subtle in this case. In fact, I've met similar patients in psych wards because the MRI was deemed to be normal. And dramatic changes could be seen on PET and SPECT, but they're often not obtained. What he had was very subtle high signal abnormalities in the cortex reflective of the anoxic injury that took place here in his association cortex. So Anton syndrome, or denial blindness, has long been thought to be a disconnection syndrome, that the visual cortex is disconnected from the frontal lobes and the cingulate gyrus. The cingulate gyrus is very important in awareness. And also, my mentor said that they are also disconnected from the temporal lobe. They forget that they're blind. And in some cases, there may be tiny bits of vision that are preserved, and the patient therefore tries to fill in the gaps. Well, last month in the Annals of Neurology, a beautiful article came out about these patients that deny their visual deficits or deny their motor deficits. So on the left side of this diagram, you'll see in red those cases of visual loss that they studied by imaging, and in blue, those cases they studied of motor weakness denial. And what they found in the middle here, in gold, is the disconnection in the visual cases to the posterior cingulate gyrus there. And in the cases of motor weakness denial, a disconnection to the operculum and the insular. In the final frame on the right, what was common to both motor weakness denial and visual denial of a deficit was that the hippocampus was disconnected. So the theory that there is disconnection to the hippocampus and the patient doesn't really recall that they're blind may hold water, and the fact that they're disconnected to the cingulate gyrus or an awareness center also appears to be important. The other thing that is fascinating sometimes that might account for blind sight, and we really do need to understand this better, and to the Riddick phenomena, that static kinetic dissociation where somebody who has a field defect can see moving targets better than stationary targets, is how do they do it? Is there a preservation of some of V1 that we just don't detect? Or is this the alternative pathway operative? That is that they come subcortically through the pulvinar nucleus of the thalamus and up through that area of the superior colliculus to the motion area, bypassing V1 as an alternative for understanding blind sight or why this static kinetic dissociation exists. In fact, there is evidence by imaging that that might be the case in patients who have Riddick phenomena or blind sight, in which there is no V1 activation in these patients, yet V5 somehow still lights up to allow them to see motion. So blind sight or Riddick possibilities are that there's an activation of V5 via alternative subcortical pathway, that there are microsaccades that are made bringing a effective field into a defective field that we just don't recognize, or as I think was present in my patient, there was likely a preservation out in the monocular temporal crescent, the far periphery, that only really sees motion well, does not see form vision well. I do believe that he had some temporal crescent sparing out there that allowed him to see motion. But not all visual loss that we see alleged has going to have any imaging correlations. Here is one.
Where'd you go? I don't see. You don't see? Oh, do you see me now?
So sometimes we have these patients who complain of visual loss. We image them, and the reality is that it is in their head, but it's not real in terms of finding a structural lesion. And these patients will often allege to be impaired and will not write their names or be able to do proprioceptive tasks that clue us in that it's truly functional. Moving forward to V2, and we talked a little bit about that, is visual agnosia, is where you see, but you do not recognize an image. You may see components of an object, but you can't put it together as an object per se. And the reality is that these patients have trouble accessing semantic areas, accessing the language areas. And often it is due to lesions involving area V2. Let's take on now some of the other important visual cortical disorders in the ventral area, the ventral stream of occipital lesions. And I'm going to interview this patient who has alexia without agraphia, a true disability, and you'll hear his story.
And detail that you have two big problems. And one of them is that you can write, and you've demonstrated that, but you're not able to read what you write. Is that correct? And for how long has that been for?
Since June of 2011, when I had my second stroke. That first stroke, I could do everything. Somehow I was able to compensate for everything. But the second one really.
Is that the one that knocked out your left field of vision, or is that the one that knocked out your right field of vision? Do you remember?
I think it's the right field of vision.
Right.
Yes,
Now,
yes.
now the other thing that
Yes.
happened is that you began to have trouble with recognizing familiar faces.
Yeah, my ability to distinguish people became extinguished little by little over time since my second stroke.
So this was an absolutely brilliant man who had alexia without agraphia. He could write fine, but he could actually not read what he just wrote. And then he developed prosopagnosia, the inability to recognize familiar faces, although he could recognize them if they spoke. And the lesion that most commonly is associated with alexia without agraphia is this lesion where there's hemorrhage here on the left side. And what it does here, particularly when the corpus callosum is affected posteriorly, is that you can't take the visual information from the potentially intact right side of the visual cortex through the area of the angular gyrus into the language areas. And so it could either happen with hitting this corpus callosum back here plus a lesion in the left hemisphere that disconnects you to the language areas. In addition, he had prosopagnosia, which is a bilateral, typically ventral lesion of the occipital temporal lobes here. As you can see, he also had that unfortunate series of strokes that caused these difficulties. So here is alexia with agraphia. We see it commonly with right hemifield defects, and we could see here demonstrated the lesion stippled here that blocks the transmission from the corpus callosum from the right occipital lobe into these language areas. Now, we talked about prosopagnosia, inability to recognize familiar faces. Sometimes you could get that with unilateral lesions. And if you get it with unilateral lesions, one-sided lesions, it tends to be right-sided lesions. And the most, famous patient I had with this was a toll collector on the Jersey Turnpike. And he would recognize everybody who would come through, and they would say, "How you doing, Joe?" and so forth. it devastated him to have a single right-sided lesion in the occipital temporal area that he could no longer recognize their faces and only by their voices, that unfortunately had to give up what he loved. And this usually results from a lesion far forward in the inferior temporal lobes into the facial recognition areas that are circled right here. Here's a patient that will describe her proboscignosia.
To interview you because you've, from the beginning of this problem, told us that you have trouble recognizing familiar faces. Can you describe how that may happen to you?
You mean how I perceive the face?
Right. Like do you recognize faces of people you've known for a long time?
Yes, I do.
But it's those faces that you have seen infrequently that you have the most trouble with. You gave it an example about that. So can you just tell us about that?
At first, I really don't recognize. I have no connection. And then they speak, and I look, and they may tell me that they're Mary, but I really have to look hard to see Mary. It remains. The perception that I see at first stays with me. And I believe them that they're Mary, and I can feel, but the face does not look the same.
Do you notice that with cars or houses that you may have seen before that you have trouble with recognizing them, or you think it's for you, it's mainly faces?
It's mainly faces.
So she had a one-sided lesion, predominantly a right-sided lesion that could cause it. She had amyloid angiopathy, an inflammatory inflammation of the vessels with deposition of amyloid in association with Alzheimer's disease. She otherwise was remarkably intact. She did quite well on immunosuppressive therapy. So this lesion right here was the cause of her proboscignosia. In lesions that cause occipital temporal lobe lesions, you may also get achromatopsia, in which you see the whole world black and white. Sometimes it only occurs in one hemifield, particularly if you knock out the inferior bank there, you get a superior field defect. You will have color vision loss even in the tact field here. And one of my patients would have trouble dressing himself because he could not recognize colors on that particular side. And so achromatopsia, much like proboscignosia, they often come together, they're very close lesions, is usually caused by bilateral area V4 lesions in which color is particularly processed. Let's just move back to the dorsal stream where we see a famous Berlin syndrome, which is characterized by three things. Simultaneous, the inability to perceive the world in its entirety, in part because they're not able to make effective saccades. They have ocular apraxia. I'll show you that, where the patient will look away from the target of regard. And they'll have optic ataxia, misreaching, where they can't use their eyes to coordinate their limb movements, probably a lesion around V6, as we talked about. They will not be able to recognize this famous cookie theft picture. They might only see parts of it. They might only see Fs, and they will not be able to see that it summates to an H, or that this F made up of Ls. They'll only see the Ls. And they may not recognize this accumbolo figure that it represents a face, and they might only see an onion, for instance. Here's a patient who has simultaneous. You'll see that he'll have particular
There's
trouble
a
with the
picture there.
cookie dip.
Just look at it. What's going on in that picture? Describe what you see.
So he's trying, he's scanning. He was taught in rehab to use his fingers. You'll see he'll try to use his fingers to scan this photograph.
What's happening?
Yeah,
It's a man.
Say that again?
It's a man.
It's a man. What's the man doing?
So we cannot see the picture in its entirety. You can't see.
The man is looking around?
Kids in the cookie jar. The
Okay.
mom is
Can you tell where they
No.
are? Are they outside? Are they
wandering
inside?
off. The sink is overflowing. Here is another component of Berlin syndrome. This is a patient who has what we call diffuse Lewy body disease, and she will not be able to voluntarily move her eyes with saccades to my finger. She'll have intact reflexive saccades, but these voluntary saccades will be off. Smooth pursuit was impaired because she had biparietal dysfunction as well.
Extending pursuit beyond the craniotopic fin line. Now look at my finger.
So I asked her to look at my
nose.
finger, which was up, and she's searching
Patient
for it
has
now
trouble
with her
finding
fast
my
eye
nose.
moves, and she can't
This is
she
a
can't
form of
find it.
ocular apraxia. Look at my finger.
She'll
There's a
look
left field
down.
cut. She can't see it, but
She'll
even in
not be
the
able to pick up the
intact
finger
field, she'll
at
have
all
trouble
with-
finding the finger.
When you're moving
Look-
too fast.
Yeah.
She claimed I was
sorry.
moving too fast.
Look at my
Uh,
nose.
And she did in fact have diffuse Lewy body disease with a PET scan done here showing bilateral parietal occipital dysfunction, showing that this area is very important for us to coordinate our eye movements to understand what we're looking at. And then this is the final case in which vision needs to be integrated and into the whole picture. This patient had a particular problem with that.
Visually, what I've been experiencing, things waver and move a lot. Inanimate objects will look like they're moving somewhat. I have some degree of control over it because I recognize what it is. I know what it is, so it doesn't frighten me, but I still can't stop it. Chairs will look like they're kind of walking, especially in grayer areas or in shadow. Things will start taking on life.
And you described, like, if you saw my hand that was coming towards you, you
Right.
saw multiple hands. Is that
Right,
correct?
yes, the hand comes forward, it's a fluid arc, and I don't know where it's gonna stop.
That's called
Uh,
palinopsia,
It,
perseveration
it
of an
moves
image.
forward, and even if you pull back, I still see it kind of like, I have the feeling as if it's coming toward me.
Your experience. So do you also see animals or things that aren't there
Yes.
occasionally?
Yes.
What happens with that?
Well, interestingly, the hallucinations, if it's dark and below me, that's when I will see an animal, and I'll see like a cat or a dog. It's usually a cat, since I'm a cat person. I'll see a cat, and that's below. That's when it's below. If it's above, that's when I start seeing the arcs and the trails. It's a very interesting because there is a distinction. I don't have hallucinations up here. I have arcs, I have lights, I have things that happen up here. Below, I'll see things. I'll see, and most of the time it's cats. Yeah, as far as the hallucinations, that's it. Is unfortunately, and when
He also had vestibular problems. He could see the world jumping up and down on him. It was very difficult for him to live in New York. He actually moved to Michigan because of it. And so we do integrate our visual signals, our vestibular signals, our sensory signals in this area between the various lobes at the temporal occipital parietal junction here. And defects in this area will cause profound problems for people like I just demonstrated. So in summary, higher cortical visual dysfunction, Anton syndrome, probably due to partially preserved vision areas versus readout phenomena where you take it in subcortically. Alexia without agraphia is a word form area lesion in which that vision area is disconnected from the angle of gyrus, most commonly seen with a left posterior cerebral artery stroke, propensognosia and achromatopsia, bilateral occipital temporal lobe lesions, but can be seen with right-sided lesions only. Berlin syndrome, which we showed you, due to bilateral occipital parietal lesions, strokes, and dementia are common causes, and then hallucinations from a variety of reasons, including sensory deprivation or release hallucinations. Thank you very much.
Thanks so much, Dr. Galetta. I think all of us are probably just appreciating the raw fact that we can see you clearly right now and put images together. Any questions for Dr. Galetta? Looks like we have one coming up here.
Thank you very much. It was an excellent talk. I wonder, you as a chair of neurology, to what level do you collaborate with people who study this from a neuroscience perspective? Lesion studies, you can lesion across the visual pathway and then see at what level, say, the camera ends and perception starts, or to what level do you work with those, or do you focus only on patients in your work? And maybe related to that, a little bit on a positive note in the end, because you showed nicely all these problems. Where do you see this going in terms of helping patients, cures and how do you study those in practice?
Yeah, those are two very important questions. Yes, of course, we would always love to collaborate with our colleagues in neuroradiology, and we do, particularly when we see these types of cases. We, try to, report them, discuss their mechanisms. And there are efforts here. It's a challenging sometimes, and we're actually trying to build those networks of scientists with clinicians right now with the new chair of neuroscience here, Paul Glimcher. But there are ongoing studies. We didn't discuss one very important syndrome, the Charles Bonnet syndrome, which is people that are blind have release hallucinations. And there is an investigation ongoing here looking at those patients. But sometimes it's just difficult to get them to be willing to come to a location where they're going to get advanced imaging, for instance. But we would love to build those relationships. Yeah, what could you do for these poor, unfortunate patients? And really, it is very tragic at times. And we send them to vision rehab. We try to maximize their remaining visual function, if there is any, by teaching them how to saccade sometimes, to make larger saccades, taking their good field into the defective field and practicing that. We sometimes ask them to, if they have a remaining field, to actually try to see if they could read vertically, because in some societies, reading is vertical and not left to right, as it is with us. We have them use their other modalities, their hands. You saw that guy trying to track something with his hands, so we try to use other ways. Sometimes, regarding the hallucinations that accompany these deficits, we try to reassure them maybe that's not enough, and therefore we have to try. So low-dose neuroleptic medicine sometimes help these people. So those are some of the strategies: rehab, sometimes medications.
Thanks very much.
Other questions? Yes.
There seems to be a variety of causes for these deficits. And my question is, are those easily identified? Are some of the causes more leading to a more treatable conditions than others?
Yeah. So the most common causes we see, unfortunately, are dementia. Alzheimer's dementia commonly can cause these deficits, and strokes. Strokes are common causes of these deficits as well. And we made tremendous strides with stroke. Now we can treat stroke, the sooner the better, but we can treat stroke potentially through the help of neurointervention up to 24 hours. So, that's a real opportunity these days. Time is brain. And there's a lot to be done for stroke. And today, we're embarking upon an age of treatment for the dementias as well. The first real approved therapy is now getting ramped up, and patients are enrolled to receive Leqembi. And there are other of these anti-amyloid agents that are on their way as well.
And also how early in the disease course can this be detected? I mean, I think at some point, obviously, there are obvious deficits, but there are subtle, like some tests that will detect this, the beginning of the deficits earlier, like for example, in Alzheimer's or dementia.
Yeah, I didn't follow the question. Dan, did you hear it well?
Oh. Yeah, so my question is, how early can you detect this? Because I assume dementia is progressive. So for example, there will be some subtle deficits to start with, and then later on, obvious deficits. So I'm
how do we
thinking in terms of like
How early
clinical-
can you detect? Yeah.
Yes, but in terms of clinical tests, it's like there are tests that can detect all
Yeah,
these
I think
deficits early.
PET scanning is very humbling that we could see changes that suggest somebody's going to go on to develop cognitive dysfunction. But sometimes there's a disconnect there where the imaging looks bad, but the patient looks good, and that can go on. So there's not a perfect correlation. We also could use CSF markers that also are helpful, but these tests are not perfect in helping us. And I think that's a real big opportunity for imaging. Can we detect the earliest manifestations of dementia, as you say, because that will be the greatest opportunity to treat those people. And I imagine that a lot of us will be signing up as soon as we see these imaging changes that you guys will bring to us.
So, so that's in terms of imaging, but in terms like of, I guess, vision tests, there are some tests that can be designed to detect early, like for example, somebody has dementia or like early dementia that is going to progress, and they down the line they're going to develop like some sort of vision problem, but which is obvious, but then it might be really subtle in the beginning. So I was wondering, think of clinical vision tests.
Yeah, so sometimes you're right. Sometimes the first appearance of Alzheimer's disease can be in the visual system. And it could be a patient like I showed you who couldn't get to my finger. That person had a normal MRI scan, and she had complaints of not being able to see parts of her world. And so going and examining her clued us in that there really was a problem despite the normal MRI scan. And that's what brought us to the PET imaging, which showed us the bilateral parietal occipital dysfunction. So I do think there is great opportunity with advanced imaging techniques to sort out some of these visual complaints.
Thank you.
Well, so not so much a question, but just one reflection, both on your talk, Stephen, and on Michaela's talk. It strikes me just how much our view of the world is constructed, not innate. And I think that's something that hopefully should be familiar to people who work in the generation of images, right? We all know that most of our modalities don't give you what you see is what you get. You have to perform this series of operations, even to generate the image before you interpret it. It strikes me that what you were talking about is all the ways that construction can fail.
Absolutely.
Yeah. Well, excellent. Thank you so much again, Steve. Thank both speakers once again.